I want to sort of transition to our morning keynote and invite to the stage four, I think, really smart and very diverse perspectives to talk about the future of healthcare in Southern California and San Diego. Greg Buchert, the President and CEO, MD, President and CEO of Blue Shield Care First. Nick Macchione, the Director of San Diego County Health and Human Services Agency. Karis Grounds, the Vice President at San Diego 211, and Abby Sears, the CEO of OCHIN. Why don't we have all four of you come on up stage and give them a round of applause, please. And Nick, I'll start with you and let you lead off. Let me start with sort of a political question, though I know you are a professional policy administrator. You work within a political environment. We talk a lot about the blue wave of the federal elections and the continued now supermajority Democratic stronghold in state elections, but there's been a pretty significant shift in San Diego County elections, moving from 4 Republican supervisors and 1 Democratic supervisor to now 3 Democratic supervisors. It's been a long time since there's been a Democratic majority in San Diego County. How are things changing when it comes to the demographics and the politics of San Diego County related to healthcare, and where do you think that might influence the trajectory of the county's work in the next few years?
Thank you. Good morning. It's an honor to be here. Of course, he just panicked me because I think he has a crystal ball looking into the future of where the county supervisors may be. But currently, to DJ's point about, there is a shift. Today we have 5 supervisors who, by the way, County Board of Supervisors are nonpartisan, but there are 5 Republicans, and they've been in office for a very long time, 4 of the 5. And 2 are terming out this month, in December. And so we have Supervisor-elect Nathan Fletcher Gonzalez coming in, who's a Democrat, and we have Supervisor-elect Jim Desmond from North County, who's a Republican. What's very interesting with the whether a D, an R, an I, is that all of them, though, are speaking to the social contract. There's been a shift locally, and I think that's also what you're seeing, DJ, I'm referring to, is the city of San Diego. City council has shifted, primarily Democratic. But whether you're on what other side of the aisle, it really resonated for me, your comments about the social contract, because I think we're having that active conversation, negotiation of the social contract right here in San Diego. And what I see in talking to both sides, if you will, on groups, is that healthcare is shifting to caring for health. And I think you, DJ, did a really nice job talking about how value-based reform has been a driver in that. But unique to the San Diego ecosystem are a number of other things, like our person-centered service, like the social determinants, which I know are very, I was gonna have a full day of talking about social determinants and how we balance those. And I think perspectives of whether you're a more conservative, come from a business development side, or you're coming from a more liberal bent and talking about the social services, you actually need both. And that's really how do you bring the best thoughts, mindsets of business-minded, they all carry, but areas of where some may focus more on economic development and others may focus more on the human development. You actually need both for that social contract as you're caring for health.
So, I'm sorry if I missed this. Did we move from 5 Republicans to now 4 and 1?
Correct.
Okay. Thank you. So, by the way, I should say that the reason we host this San Diego conference is because you put me in a headlock once and said you really need to do this in San Diego, and we used to do it in Los Angeles, and we still do it in Los Angeles, and you said, Los Angeles is in Southern California. Come to San Diego, so thank you for your support. Abby, sort of talk to me about OCHIN's engagement with some of the providers, providing sort of back-end IT connectivity amongst a diverse population of providers. And how has that experience in San Diego and Southern California, do you see it changing? Is it getting more anxious? Are people getting more open to collaboration? How would you characterize sort of the shift, or if there is a shift in the culture of healthcare as you see it?
Thank you also for having me here today. It's a pleasure to be here. And for those of you that don't know who OCHIN is, which is a lot of people, we provide IT and management services to over 500 organizations that serve vulnerable patients. So think community health centers, mental health departments, public health departments. So within that context, I'd love to answer that question. What we're seeing in San Diego is that the people that we work with want to be active participants in the social contract conversation, and it's important that we create a situation where they are equal partners and have equal fitting and can partner with the whole healthcare delivery system as an equal partner, and they're very interested and very engaged in doing whatever it takes to get to that place. And technology is one of the places that they're really looking to create new investments, looking at virtual care, looking at telehealth. How do we expand and use our workforces and make it as efficient and effective as possible, and making it as easy to talk to each other as possible. So they're looking at making sure that they're on systems that are best of breed, or that are ones that are used within the larger delivery system, so that they can share data more easily, more readily, and they want to be the first at the table to actually help move data. What I'd say on the social determinants side of it is they see a lot of the high risk, high cost patients, and it's important that they're getting reimbursement from, think of meaningful use or the high tech legislation. Some of them were left out of that. So we're really actively working to try to make sure that they have the funding and the mechanisms to actually make sure that they can be partners in the system, and that they're ready for value-based pay and ready to be a partner.
Yeah. So Greg, in terms of that safety net, I know you've got a broad background as a provider and on the plan side now, as I said, Care First, Blue Shield, also at Cal Optima previously, California Health and Wellness. How are you seeing sort of a shift in the way that we talk about and think about the safety net, the sort of Medicaid population, and particularly the Medicaid expansion population of childless adults? How would you characterize the way that we approach those childless adults today in 2018 versus where we were maybe in 2014 or pre-expansion?
Thanks, DJ. And one is, it's great to be here. Two is, it's wonderful to sponsor the conference. And just a spoiler alert, this may be the last time you see the Care First sign, since as of January 1st, we will be Blue Shield of California Promise Health Plan. So you'll see the shield from here on out. With regard to the safety net, we've evolved from the Medi-Cal mills of the past. We've evolved from the publicly funded programs county by county, some of which were run well, as they were here in San Diego, and not run well in other counties. And now that we've enrolled so many of this Medicaid expansion population, it opens up new vistas for providing services to them. The safety net has changed in terms of the people who used to serve the individuals that were 19 to 64 that weren't covered by the Medi-Cal program are either now getting paid perhaps more handsomely than they were previously, or now that the Medicaid expansion population has alternatives, they may be fleeing from their former sources of care. And this causes a lot of disruption in the system, the delivery system. It means that some of the programs that formerly served them have to step up, provide higher levels of services. It means that the new places that these individuals are seeking care need to understand a new population. And as we look at the population, it's different than the traditional Medi-Cal population. There's far more work-related injuries, far more domestic violence, issues with regard to substance use and behavioral health issues that have always been a challenge, and it just raises an increased challenge for that whole safety net delivery system. And I think it really taxes us as far as really defining that interface between physical health and behavioral health, and the challenge is to do a lot better job than we are right now.
Yeah. I wonder, Nick, let me ask you this question first before we move on. Do you see an improvement from where you sit in the way the human service world and the mental health world is integrating and working with, learning the same rules, learning the same vocabulary with the physical health, more traditional MCO side? You really come from that human service, mental health world, but you guys, that world is integrating now with the world that Greg lives in. Are those two worlds getting better at working together?
It's a great question, and of course, we couldn't have a better rock star than George Scolari right here from Community Health Group. And there are many Georges, by the way, in San Diego, and George has been at this forefront, where our own Medicaid plans, and I won't say it was easy 20 years ago, but the evolution of where our ecosystem is now, that we embrace mental health well-being, that our providers are stepping up, including our plans. What I'm very proud about in Healthy San Diego, our Medicaid plans have been meeting for 2 decades, more than 2 decades, at the table, monthly. And at the heart of this has always been, how do we strengthen, how do we deal with the ping pong of those of mild to moderate to severe, because the county is we're the Medicaid plan for the severely mentally ill. But that's invisible to the people we serve. We serve folks. And I think what's exciting is the expansion of drug Medi-Cal, if we talk about that, the first in the nation with our 1115 waiver to develop an organized alcohol and drug delivery system, the first in the nation. There is no part of this country that has an organized alcohol and drug delivery system, still. And so California, counties that are pursuing this, well, that's the whole issue about behavioral health. That's the connectivity of, it's not just a kind of siloed value-adding strategy to primary care. It's really weaving those together. It's talking about housing and the services we provide in the housing. It's talking about, next week we have a grand opening in Oceanside. It's our Live Well Health Center. It's first of its kind, where we have, get this, a Mariposa clubhouse, mental health clubhouse, a mental health outpatient, a primary care clinic, a substance abuse outpatient clinic, a veterans services, and some of the other human services supporting elements in a facility, embracing the common culture of treating the whole person. So that's why for San Diego, for the whole person care, that was another part of the 1115 waiver, we said it's not about care, it's about whole person wellness. So we have really fully embraced that, and the whole person wellness is a Medicaid plan demonstration model. And I'm proud that all of our plans participated. And I didn't have to twist elbows. They really, they did step up to the plate and said, this is the right thing to do in providing, coordinating the services. And get this, talk about value adding, where when we're not there yet, generate savings, is to reinvest those savings into supportive housing. I can't think more of a community that has really understood the social contract and social determinants as it relates to behavioral health and primary care in a managed care environment.
Karis, I wanted to have Nick sort of speak to that first, but then I wanted to ask you a similar question, because 211 is also very much a national leader in terms of, in San Diego, in terms of trying to integrate services between the mental health and SUD and behavioral health communities and other services ranging from housing to, of course, Medi-Cal coverage as well. How would you characterize, and maybe give us some examples or some anecdotes of folks doing it well, but how would you characterize the state of this continued integration process? Are the BH and the physical health sides improving in their ability to work together as you see it from 211?
Absolutely. I think, Nick always says it well, but I think we're really kind of moving the needle in a lot of different ways, and to the point of whole person wellness. We have some ACO models here. Our accountable communities for health are kind of shifting the way we're thinking about a lot of these concepts, and how we can really work together and and collaboratively share information and really address whole person around social determinants of health. So we see that also with the Connect Well system, our health information exchange, and also with the community information exchange, which is what 211 San Diego runs. And really trying to bridge that relationship between human services and healthcare services. And behavioral health is probably one of the biggest issues that we continue to see as one of the struggles we're trying to figure out. In interoperability, although housing and food insecurity, and those are kind of the easier issues that we're trying to solve, maybe not housing, but we're moving the needle on some of that work. I think behavioral health is kind of a really huge underlying issue that we're definitely making strides to address, but are still kind of figuring out how to make that work.
Mm-hmm. Nick, did you want to?
Yeah, so for Karis and 211, they're a bit modest because they are really a heartbeat of our community in terms of our interoperability. But get this, there is no jurisdiction in the nation that has created this kind of iron triangle of a 211 and community information exchange, which is getting our human servicing organization, nonprofits, that share data and interoperability, and Karis can talk about that. But we've been a beacon site. We're the only still original High-Tech Act beacon site where our hospitals, every one of our hospitals here, except our 2 for-profit hospitals, stood up and said, including with the county, and said, we are going to create a interoperability, a health information exchange, and get this, and make it sustainable. And I don't know if Dan Chavez is here, but our hospital partners, and it's just not hospitals, it's our clinics, have developed this remarkable San Diego Health Connect that is saving lives. But it didn't stop there, because the triangle has 3 points, right? So 211 CIE, you have the San Diego Health Connect. The third point, though, is the social determinants, and that is then the interoperability inside the health and human services, where we're sharing between behavioral health, child welfare, eligibility, public health, probation, housing. Now, the issue is, how do you bring these together? And that is the 3 verging kind of streams coming together, where I think in near future, we really will have a community, and it's starting now, where we're going to be sharing with a very protected environment information about the whole person, whether it's from our nonprofits and government, it's our hospital partners, our clinic partners, retail pharmacy. And that iron triangle becomes important because then it's not just about electrical plumbing. It's not about interoperability. We can plug and connect. I don't know how to do that, but you plug all these things, right? Databases. It's interoperability. Once we share data, how do we now change our behaviors? How do we change our service delivery to better provide that type of care coordination or whatever service it is? So really what we're at the thrust here in San Diego is pushing that interoperability, because we're blessed having a community coming together and having the type of investments and partners, including payers, that have been supporting this effort.
I want to build on that with each of you, Greg and Abby, and I want to start with you, Karis. Tell us, on the topic of social determinants, what is the most interesting work that you're doing at 211, at OCHIN, at Care First? What is the most interesting work you're doing around social determinants where you are?
So the Community Information Exchange is probably one of our biggest kind of movements around social determinants, and that is really connecting human service providers, social service providers together with healthcare providers. So it's connecting health and social services. And I like the way that Nick was talking about. It's really a movement in changing the way that we provide care. So healthcare, we're looking at upstream impacts. We're really looking at what are the root causes of why people are consistently having the same health conditions, and really what are the issues underlying those, and how do we connect our social service partners and our healthcare providers to really understand the underlying issues that are happening. And the only way to really do that is to work together and collaboratively share information and collaboratively change the way that we're providing care. And so with the Community Information Exchange, we're actually joining and governing together as a community with healthcare, social services, and payers, have them all at the table, having individuals consenting to have their information shared across these organizations, and being able to really address people's situations and social determinants from the point of where they're at, and really understanding the things that are going on, not only in the healthcare setting or in that moment in time that you see them, but before they came to you. Maybe what are other issues if a child, it's a father comes in, a homeless individual, and you now see that they have had, other things happening to them. They have children. They may have already accessed services somewhere else. Can you provide a different sort of care now that you understand their full situation? And really understanding social determinants of health is really changing the script a little bit and not just thinking about it from that one moment in time or in healthcare triaging and kind of discharging. It's really looking at it from what are the right interventions and what are the other things that we could be working on to really look at the upstream impacts. So the CIA is really changing the movement, not only here, but I think it's something that other communities across the nation are trying to replicate, because this is a model that's shifting the way people are really thinking about providing care.
Abby, same question.
So at OCHIN, we host 2 different electronic health records, and in both of those electronic health records, we have built out very robust data capturing capabilities for patient-level data capturing. So we have the largest collection in the country of patient-level collected data at the point of care. And we also have a very large research arm to our organization. And so from those 2 places, we've been spending a lot of time looking at how do we help the organizations collect the data, and what is the most important data to collect. We have the National Academy of Medicine's recommendations. We've been collecting that data, but what do you do with it? How do you move it? The standards for interoperability and for technology exchange of data don't necessarily incorporate social determinants of health data. So how do we get it to the right place? And once we get it to the right place, what are they going to do with it? And where is the right place to actually be sending it to? And it's an additional burden on the provider system to be collecting that level of data. So if we're not doing something meaningful with it, then why are we doing it? And then the next thing, one additional layer that we've been really looking at is, okay, now that we do have patient level data and we do have really robust clinical complexity data, what are the correlations and what are we finding about those patients, and how do we do interventions, and what types of care can we what interventional studies can we create related to that? And so we're doing a lot of work around what's our quality of care when you risk adjust for social complexity and medical complexity, and we're finding that based off of that information in our health centers, their actual quality is outperforming a commercial population, which is fascinating if you think about that. So now we're trying to think through what do we do with that information as well. So there's a lot of research around how do we get the data in, what is the most meaningful data, how do we get it to where it needs to go, and where is the right places that it needs to go.
So say that again, when you risk adjust for social factors,
and medical complexity.
Some of your providers are providing a higher level of quality
In
care
Correct.
than in the commercial setting.
In aggregate, they are providing higher quality than they are in the commercial population.
Huh. Greg, same sort of thing, and let me sort of preface with this touch of cynicism, which is I feel like we've been talking about social determinants a long time, and I do credit Medi-Cal plans, I credit Care First with being sort of really on a cutting edge nationally and trying to figure out some of these, some of the answers to these challenges. What is the most interesting stuff that you all are doing? Because you've been thinking about this a long time. So what is exciting to you in the way of social determinants?
I think one of the things that differentiates Care First from some of the other health plans is a real member focus. And I think the most exciting thing we're doing right now is connecting the dots at the individual member level. And by what I mean is, number one is we're screening for social risk. We're using the Prepare tool to screen members coming into our clinics, and we'll be rolling this out to other providers to say, are people going to bed hungry? Do they have stable housing, and so forth? We're using ACEs to look for adverse childhood events that really create major challenges for people and for individuals and their families. So then it's, okay, we found that, what do you do with it? So we're expanding our relationship with organizations, with the various community-based organizations, and working with groups like 211 and working with groups like Healthify to say, how do we make sure that all the people at Care First know who to connect them to address some of their needs, resource needs. We're using groups like, I saw Abner Mason here with Consejo Sano to do texting in multiple languages in culturally sensitive language to make sure that people know what to do. And we've recruited a number of health advocates who bring that human touch from the health plan perspective to make sure that it's one thing to say, we know what challenges you have, we know what resources are there, but sometimes it's pretty hard to navigate the system. And so there's a lot of hand-holding that goes on now that didn't exist previously.
Yeah. Nick, you know, since it's just you and me here over a beer, I wouldn't say this publicly, but it seems to me that San Diego County has done just such a good job as a purchaser of mental health and behavioral health services, and is using dollars in very innovative ways like the Mariposa Center you just mentioned, which I'd love to come back to. And because of the geographic protected, isolated sort of space here, and because you've got a large county, and because of the culture and your leadership and others, where you have kind of a hierarchy of all of the different, or a hierarchy within which all of the different sort of divisions and programs play nicely and well together in a unified voice, wouldn't it make more sense to have fewer than 7 MCOs? And moreover, wouldn't it make more sense to have the county really be a very directive force for maybe 1 or 2 or 3 MCOs, where you could purchase and drive culture change and reform in the same way you do on the mental health side?
What beer number are we up to? During this conversation?
I think you need sugar and alcohol.
Well, you know, all candor, we were doing pretty well with our 5 plans. And we have a bigger family now. Aetna and United joined us. And so we have 7 plans. And talking with, was it the hospital association, with our different association leader partners at the table, what I hear more often is, it's too much. We want choice, but it's too much too. So to DJ's point is there something missed in having such a big motley crew of group? Here's the interesting thing in San Diego. And we have the state coming down to study the geographic managed care. Sacramento struggling a little bit with their geographic managed care, the ability of having health plans and the way we operate here in San Diego. San Diego and Sacramento, the only 2 counties. But we've been able to make it work. And an interesting, you know, if you describe our market, it's really a co-opetition market. We have fierce competition. But we've been able to find ways to collaborate in a meaningful way. And there's endless examples, truly, of that, including within the plans. The testimonial that you've been able to get Medicaid plans come to the table for over 2 decades and work together for the best interests of the region. I think for us, yes, has it been a challenge? It has. On the eligibility side, it's more forms, it's more choices, it's more, you know, of the discussions that we have to do in our healthcare options requirements for the state for eligibility for Medicaid. But we've been able to make it work because I think what every one of these providers bring, plan providers at least, purchaser buyers, have been new ideas. And so really the beauty of our design has been to try to take out the best. So I'm not trying to, you know, sugarcoat this, but I think that we have been able to make it work at a time when, frankly, we thought we were going to go from 5 plans to less number of plans, and yet we went to more. So I think to answer that question honestly will be a few more years out, because we're still too early into this process. But I will say to this point, we've had great participation by all 7 of the plans, and some stand up even more than others. We really appreciate Care First's support for things like this, but all of them have really, community health group, all of them have stepped up. And so as long as they're adding value, the way I look at it is, are they adding value? And does that take away from then, you know, more of the loss of economies of scale, if you will? But I thought for a moment you were going to go down the line of, when you talked about the county, that you're talking about a county organized health system. That's a whole nother entity, and that's Cal Optima, just north of us. So we can look, and you can look at the HEDIS measures, and you can make comparisons, and we fare pretty well, even not being a county organized health system, by having this type of participation. San Diego has a long history of public-private partnerships, and I think we're blessed in that public-private partnership, because it brings out the best of our community partners. I don't call them contractors, partners that come together and actually have niche markets they could better serve than the county would do, as well as bring fresh perspectives that would be perhaps more of a single mindset if it was a county-run system. So I am fortunate to have the type of diversity of the plans that we have.
Mm-hmm. So you'd recommend it for every county?
No.
Abby, let me ask you, how do you, so OCHIN is in a number of different states up and down the West Coast, and how many states are you in now?
Well, we're in 47, but with our EPIC hosting, we're in 28.
So almost all of them. How do you characterize this community in San Diego within the context of some of the other communities in which you serve? In other words, what makes this place different from a perspective that is informed by engagement with a number of communities?
Well, it's its own country unto itself down here. So one of the things I do think makes it entirely different is the county system and the county's agenda, which I think is very organized and very visionary. And we don't see that everywhere. They really do take a leadership role, and I think the coalescing that the county has done has really driven a single agenda, and I think that is very profound and very lucky. I do think that, though, in this environment, it's a very competitive environment, and so that's an interesting thing to navigate as well. So how do you partner and then manage through that at the same time? But when we're in Oakland, it's very, very different than when we're in San Diego, and so you have to kind of adjust your approach a little bit. And I would say that the community health centers, I think, provide a very vital and very, very important part of the delivery system. The primary care system, the public health system as a whole in this country, are under a little bit under siege, and the small practice no longer exists the way that it did, and I think that's amplified in San Diego. So I think that they are trying to find their voice and trying to make sure that they're a good partner, and that feels different down here than it does in Central California or Northern California or in other states as well. And so I think that we experience that, and trying to help them have that voice is probably one of our goals.
I want to ask everyone one final question, but I want to ask you, Karis, just briefly, because we're starting to get short on time. What lessons are you learning at 211 about these wildfires in LA and Northern California? What do you start to think about as a result here in San Diego County?
Yeah, I think that's a really interesting new concept and a new issue that we're starting to surface more and more in California, and specifically in Southern California, as we just had our LA wildfires, and that's something in conjunction with the county. We respond to public inquiries when people are calling in to know where to go for the non-emergency line, and we know that that's something that we do have to put on the agenda, and something we do have to be thinking about in the future is these environmental health and how these fires are, how we prepare and how we respond, and how these environmental impacts. I was just up in San Francisco last week, and the air quality in San Francisco from all the fires was so bad, and those are kind of things that may be happening here locally as well. So us preparing as a community, and also the policies and the response that we need to have, and the healthcare impacts of that as well, is something we should be thinking about too.
So Greg, and this is a question to each of you. We'll start with you though first, Greg. Give us one big, bold prediction for healthcare in 5 years. What is the most interesting thing that we don't see, maybe don't fully see coming or don't fully appreciate, that we're going to see in healthcare in 5 years' time? I actually do really like you.
I know. My prediction is that all of the Medi-Cal carve-out programs will all be consolidated under the managed care plan. So currently, if somebody has a complex case, they could have the health plan and California Children's Services and Regional Center Services and County Behavioral Health and dental and school-based services and still fee-for-service activities. Obviously, a lot of administrative cost, a lot of challenges in coordination, a lot of confusion to the individual member. So that's my prediction. They'll all be consolidated.
That's a big one. Karis, how about you?
Well, mine's not too innovative, but my hope, I guess, the value-based care is something that I think we definitely need to prepare for and be thinking about, and contracting, or I don't know if it's the right word, partnering with social service organizations around healthcare as a whole, and really thinking of that social services become more a part of the healthcare infrastructure in the system and the funding mechanisms and the community support that's needed.
Abby?
I think that the way the patient engages with healthcare is going to dramatically change our landscape. I think the idea of healthcare with four walls is going to change. I think the choice that they're going to have is going to require us all to operate in a completely different way. And I think how we're delivering healthcare is going to look very different between 5 and 10 years.
Good. Nick, last word?
I think what I'm excited about for San Diego is building out a continuum of care. I think we'll be the first in the state having end-to-end integration in our behavioral health system of care, from dealing with people in crisis and the avoidance of that and trying to keep them thriving in their home, to building a very highly innovative, distributed inpatient mental health system throughout our county with many of our hospital partners and community clinic partners. And then the issue about the step down and the coordination and thinking really creatively so that when we're putting and having people leaving the hospitals, their coordinated care, they're not recycling through, but we are really in a rehabilitative path, and we're going to see very measurable, very substantial improvements in our behavioral health system. And I see, Luke, Dr. Bergman here, and our behavioral health director, but many of the folks in this room, this is what we're building together in this region, and I think we're going to see that in 5 years.
Let's give them a round of applause.